For the next 45 minutes, I'm going to be describing specifically one tool that we took from the Toyota production system and applied to healthcare to change our culture of blame and secrecy to one of celebration and recognition. The objectives, I'm a nurse by background, as you've already heard, so we're tuned in to designing objectives. Today, what I would like to do is talk about what the strategies we used to enhance a culture of safety in your organization, and understand how the definition and demonstration of what we call respect for people is so incredibly important as you engage your people to telling you what are the systems and processes that need to be corrected. So I'm guessing, but correct me if I'm wrong, Israel's not much different than the United States in terms of blame. The nurses blame the pharmacists blame whomever, the doctors blame everybody, right? Very much a hierarchical, and historically, you were not allowed to open up your mouth to someone who was in a higher level, perceived level of importance. So in order to create a culture and a system where people are raising their hands and saying, I just made a mistake, we were unable to do that immediately, right? Because we had to change our culture. So I'm going to tell you a little bit about what we did and how we did it. Our vision is to be the quality leader. What we call these are our sub-strategic plans. I was the executive accountable for the quality strategic plan for 20 years. And the goal was to relentlessly produce the highest quality outcomes. It was our belief that in order to produce the highest quality outcomes, you had to have an environment of patient safety, because patient safety really is the foundation of quality. You can't have good quality if you're making errors, right? It doesn't make any sense. So we were focused on that. How do we change the behaviors of the people in the organization from that of a blaming, yelling, fearful environment to one in which every nurse, every patient care technician, every physical therapist is willing to raise their hand and tell us, I just made a mistake. Only by the grace of God did I not hang the wrong IV solution with this patient, which happened to be the very first time. I was so excited. The very first time when a nurse self-reported, because she grabbed a bag of fluids that had been put in the wrong container and was going to hang a fluid that would have harmed the patient, and she was willing. But that took us a couple of years to get there. So this is not something that happens overnight, necessarily, right? Sounds like you have the same steep hill to climb that we did. So how did we do it? Before we implemented even the Virginia Mason production system, I had been a student of patient safety since the late 90s, when there's a book called To Err is Human. Many of you have read that, right? So that's when the dirty laundry got out, that we actually hurt people to the tune of about 100,000, minimally 100,000 people every year in the United States dies because of a medical error. Are we safer now? Probably, but I also think that our eyes are more wide open in terms of what we call an error, and so I don't know that the number has actually changed all that much. So the Lean, or the Virginia Mason production system, is the way that you design safe systems. But as we said, we have to have a culture in which people will tell you what are the systems that are getting in the most way of the people and causing them the most problems, right? You need to have a organization or a culture, and I've talked to a few of you who are really interested in doing this in your organization. And there's, to cut to the chase, if you don't have the executives on board, there's a certain amount that you can do within your own area of domain or power, if you will. But to really make this huge difference sustained over time, it's important to get your executive team to recognize this as an important change in how they do their work, which means being willing to learn from your mistakes, right? Being transparent, saying, we made X number of errors. There are a couple of hospitals now in the United States who actually are willing to say it's been X number of days since we last hurt somebody and make that public. It was a huge public media fear about going public with what we were when we harmed somebody. And that's something that I understand from the folks that I've been talking to, that's also a concern here in your country. Is that true? Not so much the lawsuits and claims, but more from a public opinion. Is that right? Yeah. So this is a checklist. You have to deal with each one of those. So if you're a quality manager, I've talked to some of you in a laboratory, there's a certain amount of things that you can do in your laboratory. But to really make this a systematic approach to improvement requires an organized, focused opinion. But we'll talk about how you might do that. I shared with you that the entire executive team talk about public opinion. Our CEO just made the decision that we were going to all go to Japan after we've been studying Lean for about 18 months. We were all going to go to Japan and work in the Hitachi air conditioning factory, et cetera, for 14 days. As you might imagine, some of our people back in our organization thought that we were all going on a 14-day vacation, right? So they, a couple of them, I don't know how many, decided to take the opportunity to let the local media know that their entire executive team was going to Japan, but that was a risk that we chose to take. Yes, did we get some bad press? Yes, but we felt that it was important to do it. So we went. Finally, on the day 13 is when we finally got to the Toyota Motor Company. And if you can imagine a manufacturing floor that's the size of 35 baseball fields, but huge. There's this very slow conveyor belt. And at any given second, there's between 300 and 350 cars on that rolling conveyor belt. They know for those of you who know Lean at all, their takt time and their cycle time so well that they have these little lines on the floor. And we're up on the catwalk. We can't be right on the assembly line. But we're seeing these high school trained assembly line workers pulling a cord if they can't get, say he's putting in a steering wheel. If he can't get the steering wheel in before this little line here, then he pulled that cord. And it slowed the entire 35 baseball fields, 350 cars, multi-million dollars. He slowed the entire thing. And if he still couldn't get the steering wheel by this longer line, he pulled that cord and stopped the entire production. I'm standing next to the chief nursing executive. The first time we see this. Lights are going off, and we're seeing the supervisors run. And we're saying, oh, he's in trouble. But no. What we saw, and this happened many times over the hour that we were observing, many times workers were doing that. Why? Because it's more important to Toyota that they fix whatever that problem was, that quality problem was, before he sent it on to their next coworker, because quality was that important to them. How many times do you have to deal with a defect that's handed off to you in healthcare? A few times a day, a few times an hour, a few times a minute. We're fraught with that. But it's more important for them to make sure that every single thing is handed off correctly. We were amazed. There's 32 executives. The next day, we're making our final decision. Do we adopt the Toyota production system as our management system? And our CEO asked the question. Our patient is at the top of our strategic plan. It is our true north. Shouldn't we be doing this for our patients? This is the year 2002, when across the United States, I don't know about in Israel, 35 to 50 people were dying every single year due to ventilator-acquired pneumonia and central line infections and many other things. We didn't know what a complication was, or what was a mistake, or what was a defect. There was a lot of fear in the room. Finally, after about an hour of discussion, there was a lot of us who said, not I was supportive, but there were, the chiefs of surgery said, how do I know if somebody comes in with a dirty wound, is that a defect? Is that something that we stopped the line for? We had so many broken processes, we were afraid we weren't going to ever get the process started again. And certainly from a culture perspective, we knew that it couldn't be that patient care technician or that nurse's aide that was going to be able to pull that. So we knew that we as the executive team was going to have to drop everything we were doing, go to the gemba, the Japanese term for shop floor, and decide, is it safe for another patient? Because our intent was to make sure that not even one more patient got exposed to whatever that system or process was. Our old system, you might probably have something similar, quality incident reporting. It would be months before we would ever get around to doing it, if we ever did do a root cause analysis. Quite frankly, I'm embarrassed to say, sometimes we just read the reports and stuck them in a file cabinet. So we also had a cultural issue because our people weren't, when we started down this process, they didn't believe us that we were really going to stop everything that we were doing and come and fix it. But we decided that we were going to do that. I didn't even have a patient safety department at the time. I had a risk management department because, again, in the US, we're highly litigious. And I had a quality resources department. There were 6 risk managers and there were 2 quality people that were trying to read medical records. In those days, they were paper and look for bad apples, somebody who'd made a mistake to slap their wrist. So we changed and decided we were going to do a patient, what Stop the Line was too manufacturing sounding, so we called it a patient safety alert system. We changed from a Monday through Friday, 8 to 5 staffing to 24 hours a day, 7 days a week. We committed that there would be an administrator and a patient safety person who would drop what they were doing, go and see what was going on, decide whether or not that system or process needed to be taken offline or whether something quickly could be fixed right at the moment. In our case, there's some legal requirements, and we knew that there would be times that we would not have a clear answer right away, right? Because healthcare is complicated. And so say somebody dies in the operating room. Was it a physician that was impaired? Was it the wrong patient selection? There could be lots of different reasons for it. But again, we wanted to make sure that not even one more patient would be exposed to whatever that was. So we had to do some administrative and legal safeguards because we knew there would be times when a nurse would be taken offline and put on administrative duty, same with physicians, et cetera, while protecting them, paying them doing other things, but they weren't going to be doing whatever it is that they were doing until we got to the root cause. We wanted to make it easy. At first, in those days, they called. It was a telephone. We got a new phone number, 30,000, easy to remember. After hours and on weekends, it set off a pager where the patient safety person would follow up and then call the administrator on call. And they would come in and we would sort out things. Now we've had an online system for 10 years. Very often, though, busy nurses on the floor don't want to even fill out the online tool, so they end up calling anyway, so we have both systems. But if they are calling and it's after hours, we instruct them to call because the online system doesn't trigger the pager. Back to the compacts. This, again, and managing behavior choices. This really became an effective and essential tool as we were implementing the patient safety alert system, because there was conversations that would have to occur because of disruptive behavior. There's a rule that all hospitals in the United States must have a process by which you manage of not just physicians, anybody who yells and screams and throws instruments, for example. That was the standard behavior in the past. That is considered a patient safety alert when that type of behavior occurs. It is considered what we call a red patient safety alert, which is the top priority. It means an executive comes to manage the conversation with that person. And we use our compacts to have those conversations with those individuals who are not exhibiting behavior that is acceptable for a culture of safety. And I can talk about some examples of that. Well, actually, I'll give you one example right now. So, we implemented an online computer order entry system 10 years ago. And we didn't do it very well, quite frankly. I mean, we implemented the technology, and the younger physicians who grew up with a computer had no problem at all. But we didn't support the physicians of my era who had some difficulties with technology. And so we had a case where a physician and the organization made the decision, on one day you're writing physician orders on paper, the next day everything has to be in the computer. We didn't give people the option. But we didn't support the physicians who were struggling with the technology. And so we had a physician who was a nurse surgeon who just lost it. He had a sick patient. He didn't know how to use that box on the desk. And we didn't have support there. So he yelled and he screamed, and there was a patient safety alert, and he was taken offline immediately by the chief. But we used the compact. We had that conversation and said, what happened? And was his behavior inappropriate? Absolutely. But there was also what did the organization should have done and didn't do? We didn't provide the training and the support that he needed with that type of technology. So now, every time we have new technology, new update we use Cerner for our electronic medical record. Every time we have a new update or new software or a new tool, there are people all throughout the hospital floors with bright green lanyards so that the docs and whomever knows that they're an expert, they're a super user, and they could go to them. And we also have a whole command center that people that are there 24 hours a day for the first 3 weeks, all because of that patient safety alert, right? So you can't act like that, and the organization has responsibilities to making sure that you have what you need to function respectfully. So when we first started, we were very, very afraid, as I mentioned, because we didn't know that we'd ever get started again. So we called, we still had our quality incident report for the minor stuff. And we called a patient safety alert. Anything that was significant would be considered this new process that would be a patient safety alert that would call in the resources, et cetera. And we learned over about 2 years that the lead time between the time the notice came in and the time we actually started working it was getting longer because we were, 2 reasons. Number one, we were trying to figure out if it was significant or not, or if it should go through that other system. More importantly, from my perspective, we were getting feedback from our people saying, I thought you wanted me to tell you when there was a problem. This, to me, was significant. So we were talking out of both sides of our mouth, which was not going to help our culture, right? So we had what's called a Kaizen event, a 2-day Kaizen event. We had the CEO, the chiefs come together and come to agreement that we're opening up the floodgates. We're no longer going to have a quality incident report. Everything was going to be a patient safety alert. But we had to color code it because an outdated tuna fish sandwich in the patient refrigerator just doesn't rise to the same level as a death in the operating room. So yellows, and over the last 10 years, this has been pretty consistent. About 90% of them we consider yellow, meaning they're at the far end of the sharp point, the outdated tuna fish sandwich, for example. Interestingly, our board is as much interested in those yellow ones as the red ones. Why? Because that's what we need to be thinking about 2 years, 3 years, 4 years down the road, or as far as systems and process improvements. The oranges you could put in the bucket of near misses. Those are the only by the grace of God did I not give this person the wrong medication. And then the reds are actual harm, behavior issues, and allegations of sexual misconduct. The reds still require an executive to respond, and they're the ones who run the root cause analysis with the help of a patient safety specialist. They do their investigation, decide whether or not that process or that individual needs to be taken offline, and put some improvements in there. The oranges are more at the director level responsibility. The reds, the executives have to respond within 1 hour. So from a standard work perspective, 1 hour associated with that. 24 hours for the near misses, where it's usually often directors with a near miss, the director of nursing working with the pharmacy director to figure out what happened with the medication error. The yellows are the frontline supervisors working on them. And they can be not enough IV poles or Alaris pumps or something to that nature. Our board quality committee is very invested in our improvement efforts. And initially, the red patient safety alerts, once we decided it was red, once, say, the chief nursing executive conducted the root cause analysis and made the improvements, she would say, I think I've fixed this problem. And I would review it and say, okay, yeah, I'm comfortable with the fix. Or no, you're not comfortable. I'm not comfortable with the fix. You need to do more. But what we started learning in 2007 is that some things kept repeating. And so our board said, you know what? We want to be the ones to decide whether or not this red patient safety alert has had enough improvement done. And these people are not clinicians, but they ask really good questions, and they help us get out of what we call our mental valleys about, oh, well, that's just healthcare, and help us to think about it in a different way. We came back from Japan on, I'll never forget it, July 4th, 2002. We made the decision to implement a patient safety alert system on July the 6th. I had 6 weeks to create a patient safety department, create policy, hire people, and get started. And so we were really building the airplane as we were flying it. So immediately we started using our management system to improve, right? And we thought we were doing really well. And I was speaking internationally about this at the Institute for Healthcare Improvement, and we were really thinking, okay, we've got the answer now. We've changed, and we're not going to make any grave errors. And then we did. This is the photo of Mary McClinton. Talk about bad press. This went international. She was a woman who we failed. She came in for a complex but routine neuroradiological procedure. And there was a human error. Prior to that, there had not been a policy to label stainless steel bowls filled with fluid on the back tables of procedure areas. And the technician mixed up, and the other variable was that we switched from a brown cleansing solution to a clear solution. So we had 3 clear solutions, all unlabeled, on the back table in a procedure room. And before this happened, it was no big deal if we mixed up contrast and saline. Unfortunately, Mary McClinton was injected with chlorhexidrine, which is a very toxic antiseptic, and she died a terrible death 3 weeks later. Because we didn't know where throughout our organization there were situations where there were stainless steel bowls with unlabeled solutions, we made the decision to inform the entire organization what we had done and say this is the new standard work. We did that within 24 hours. That again got to the media. It was painful, a lot of exposure. And what I didn't recognize at the time, how hard it was for us who are clinicians. We knew that we hurt people, that we made mistakes. But what I didn't understand was that the administrative assistants and the accountants really didn't believe that it happened at Virginia Mason. They really thought that, well, that must be all those other hospitals. So that was huge for us. We tried to turn lemonade from lemons, and we now use her image. As one person said, she is the face to all the statistics. And when we're trying to work with a group to comply with hand hygiene or to do a new procedure for safety, we use her image. We also celebrate who's done the most for patient safety for the past year with her image. So this is a photo. Again, so you got to get people to tell you what's going on, and you have to celebrate and recognize those who are giving you indication of what needs to be improved. So this is what we call a Good Catch Award. They happen monthly. This is a person in our anesthesia clinic, the one with the good catch with the baseball, which is signed by all the board members. They get this photo taken. They get a certificate, which is there. Most importantly, we post it, and we cover it in all of our management and physician meetings to honor and recognize them. And we put it on our intranet so that people can blog about them. And so, again, celebrating willingness to tell us what's wrong. We share our lessons. This is a patient safety alert newsletter that was produced. We haven't done it for the last year or two, but this is telling people, all 9,000 people, 8,000 people, and our board members, these are the kinds of trends we're seeing with patient safety alerts. Being very transparent, we're seeing X number of this, X number of that, and always celebrating the most significant patient safety alert for that 3-month period of time. And then I would also use it for what we call a risk register. So when I'm trying to figure out what are the quality and safety goals that the organization should be focused on for the next year as we start our strategic planning process, we use our data from our patient safety alert system to help us understand where the errors are. I've mentioned several times about respect for people. Paul ONeill, who's a former Secretary of Treasurer, these are his questions that we stole shamelessly from and have adopted, which is that every single person in our organization should be able to say yes every single day to all 3 of these questions. We're not there yet, we're working on it, but we're making improvement. So whether you're the highest paid neurosurgeon or whether you're the housekeeper on one of the floors, you should be able to say that I'm treated with dignity and respect, that I'm thanked for my efforts, and that I have the resources and tools that I need. This is the playbill. Again, like the compacts, we didn't tell the people. We actually got a group of about 500 staff to tell us what do they think are the top 10 behaviors that we should be focused on. And when we rolled this out, we actually now, on an annual basis, every single person from Gary Kaplan, the CEO, everybody has to choose 2 of those behaviors that, you know what, I think I could do a better job of. So I continue to work on express gratitude. Because the way I was raised, you're just supposed to do your job and I shouldn't have to get all excited about it. So I have to work on that. That is a behavior that a lot of people think is important. So I need to work on expressing gratitude when one of my people has done good work. And listening to understand is the other behavior that I was focused on. So every single year, we go through an exercise across the organization where they're selecting the 2 behaviors. You know, sometimes the behaviors change, sometimes they don't. It's part of our People Link board that I showed you, so that everybody knows that Cathie Furman is working on listening to understand and expressing gratitude. So if somebody does something really great and I didn't express gratitude, then they can have a one-on-one conversation with me. Hey, Cathie, I understand you're working on expressing gratitude. It's right there. Listen, see what I did? Why didn't you, And then what am I supposed to do? I'm supposed to say, thank you for that. I will work on that in the future. So it's a way in which to have those non-threatening conversations, regardless of whether you're the boss, whether you're a doctor, whether you're a scheduling clerk, that you can all have something to focus on. As we continue to do our improvement, applying our management method, the number of patient safety alerts have gone up. And these are some of the quotes to me that define why culture is important, why you have to change culture. One of the ones I talked to you about, Mary provided the face to all the statistics. One of the ones that I love is, and actually it was not an employed physician, it was a physician who used our hospital who had to go to another place to do his surgery, and because of what we've done with the surgery timeout, he came back and said, I can no longer practice without the surgery attestation at Virginia Mason, because he recognized that people weren't helping him from making a mistake. And so those are the kinds of things that make the difference. Summary, stopping the line requires organizational involvement. From the people have to tell us what's the matter. Leadership investigates and resolves the issue. And then our board reviews and approves the closure of any red, high severity one. We have over, as of, I'm sure we're at 80,000 or more, which is, again, the data that helps us understand what are the systems and processes that need to improve. And back to the leadership. So this was a really good example. This is my colleague, my partner in crime, the medical director of quality, And after Mary McClinton, he's a clinical anesthesiologist, and he would spend time walking the operating rooms every week, 4 months, for years, and he would still see stainless steel containers with clear solution without labeling. It's just saline, Bob. Don't worry about it. So, but the leader has, just because we sent a memo and we said this is the new standard work, that's not enough. You have to be out on the floor, seeing what's happening, and then engaging your people, because their frustration was that the label didn't stick because it was wet. And then a few weeks later, one of the scrub techs came, and she was so excited to Bob, and she said, "Hey, I figured it out. I've got it. I've got the answer. You put the label on the plunger, and then you put it in the syringe, the barrel of the syringe, and it sticks." So then it was no longer a problem. So engage them in coming up with the ideas for how to improve. So our lessons learned: large-scale cultural change requires leadership, perseverance, and alignment. Can you do this on your own? As a, if you're not an executive without the, yes, you can make some improvements, but over time to sustain requires a focus of the entire organization. That is my belief. It's incredibly important to recognize and celebrate when people raise their hand for the first time, because that's a really scary thing, and you need to encourage them to say, yes, I'm so glad you did this. And then we didn't do this at first, but we actually, because we were worried, because of our culture, that if we asked you to come in and help us with the root cause analysis, that you might be intimidated by the executive and the other higher ranking people. But we do that all the time now. And we actually now include our patients whenever we can with our root cause analysis. So there you have it. Thank you very much.